Hi, today I shall give you a short introduction to health economics. My name is Gary. I studied in the National University of Singapore with a basic medical degree. I have two masters, one in public health, one in business administration. My current role in National Healthcare Group is a public health physician. I'm also a clinical advisor on AI and healthcare, workplace health, and I also work as a primary care doctor. You can connect with me on my LinkedIn. So let's start. By the end of this lecture, you'll be able to understand the fundamentals of health economics. We will define things like scarcity, opportunity cost, efficiency, and equity in the context of health economics. We'll also cover briefly the differences between some of the common analyses we use, such as CEA, cost effectiveness analysis, cost utility analysis, as well as cost benefit analysis. We also compare the different healthcare system, Beveridge, the UK model, Bismarck, Germany model, and of course, Singapore, and their implication for healthcare delivery as well as financing. Finally, we'll cover a bit about risk pooling, moral hazard, and adverse selection beneath the health insurance framework. As mentioned previously, my slides will be divided into 6 parts. First, introduction, key concepts, health insurance, economic evaluation, healthcare system, and finally, conclusion. Let's start with health economics. What is health economics? It's a field of study that focuses on how healthcare resources are produced, consumed, and distributed. What we're looking at is efficiency, effectiveness, the value and behavior in the production and consumption of health and healthcare. What's the importance of health economics? It's used in decision-making in healthcare. It's used for cost control, as well as equity and access. To sum up, it's something that helps policymakers, providers, insurers make informed decisions, as well as trying to control cost containment to deliver healthcare services at the most cost-effective manner, and finally, to make sure that we are doing our best to distribute them fairly and that there's equal access to care for all segments of the population. So our journey started when I first read this book by Victor R. Fuchs on Who Shall Live. It was given to me by my mentor, Dr. Wong Chan-ying. So basically, he is a prominent American health economics who is often regarded as one of the founding figures in the field of health economics. In the book that I received, he argues that decisions about healthcare are fundamentally societal choices reflecting both values and priority of the society. For example, in certain society or in certain countries, such as USA, there is not really this thing called universal healthcare system because their values and priorities focuses on individual responsibility. So Victor Hughes also explores how different society allocate healthcare resources and how this decision will impact the health outcomes of population. Next, we move on to key concept, scarcity. In economics, one of the easiest way to define economics is the management of scarce resources. Healthcare is unlimited wants and needs. All of us want to live to a long life. And in theory, we could actually have access to that in terms of ventilator. With a ventilator, you can potentially not die, but are you actually living? Next, opportunity cost. Basically, this is the value of the best alternative that's foregone when a choice is made. So this is something that needs to be feasible and something that is practical. So this means opportunity cost. For example, what could you have done instead of listening to my lecture? The time you could have spent on something else like reading a book or spending time with your loved ones. Efficiency is about how do you achieve the maximum possible health benefits with the resources given. There's actually 2 types of efficiency, technical efficiency as well as allocative efficiency, of which we will not cover in this lecture. Equity, fairness in the distribution of healthcare resources and how people have access to healthcare services. Whether is it fair, whether it's equitable. Health insurance, on the other hand, is another concept that we often covers in health economics. It's about 3 things. risk pooling. How do you pool the risk of many individuals together? Because most people are unable to afford a catastrophic hospitalization. But because it's a relatively rare event, we can pool resources together such that the person can be covered. And the key thing is that for health insurance is that it must be for something that is not common. If it's very common, then risk pooling doesn't really set in, and the person is maybe better off saving for his own needs. So healthy individual will subsidize the cost for those who require more care, creating a balance. Moral hazard simply means that if you are covered, you are less likely to be taken care of your own self and more likely to use resources. For example, because you do not bear the full cost, you tend to be more reckless in your healthcare lifestyle, in your lifestyle, resulting in greater care. Adverse selection refers to when individuals with a higher risk of care most likely to buy insurance. This will lead to higher cost for insurer and definitely raises the premium for everyone. Next, we talk about the three differences in terms of cost effectiveness, cost utility, and cost benefit. Cost effective analysis refers to the cost and outcomes of different interventions. So they are usually measured in natural units such as life years gained or how many cases prevented or amputations avoided, for example. Cost utility is simply a specific form of which we use quality adjusted life years as outcome measure. And this is why the difference between, and it's commonly used when you compare different interventions. Cost benefit analysis will actually compare the outcomes in terms of monetary terms, which is not so easy because what is the cost of a life? This will allow you to measure directly whether the benefits will outweigh the cost. Finally, talk about healthcare system. So the UK system, which is the Beveridge system, is funded primarily through taxation, whereas a Bismarck model is more ground up in the sense that it's funded through compulsory insurance, in this case, mainly from company-sponsored insurance. In Singapore context, we actually use a series of individual savings in the term form of MediSave, as well as compulsory insurance, MediShield Life. And for those who require better quality services, they may even buy private shield plan. Providers-wise, it can be a mix. For a Beveridge model, mostly it's public providers, but of course there are some systems where they can equally establish private providers. For example, in the UK system, most of the primary care is provided by GP, which are actually sole proprietor or they are considered as private. Bismarck model sometimes have a mix of both private and public providers, same as the Singapore model, where CHAS, which is a community health assisted plan, can be used for private GP, general practitioner, to provide for chronic care management. For a Beveridge model, the unique thing is that it's free at the point of service, so that there's no co-payment. However, the problem is that the co-payment may actually encourages unnecessary usage. And finally, for cost control, government regulation and budgeting will affect the Beveridge model. In terms of Bismarck model, it's more of how do you regulate the premiums and fees. And in Singapore model, we have the Class A system to kind of dampen the increased price in the private sector. And more recently, we even have certain price guidelines on what are the usual fees that are being charged by private providers. So in summary, we have covered what is health economics, how it's essential to optimize healthcare resources allocation. We have covered certain key economic concepts such as scarcity, opportunity cost, efficiency, and equity. We have also covered briefly the three differences in terms of analysis, cost effectiveness, cost utility, as well as cost benefit analysis. We have compared the three different types of healthcare system, the Beveridge model, Bismarck Singapore system, as well as we have covered risk pooling, moral hazard, and adverse selection. Thank you for your attention. We shall end the lecture now.